offering to enlighten us. So I'm going to let you introduce yourself and your topic as well. Thank you.
Thanks, Ahmed. Thanks, everyone, actually, for having me for today. This is one of the cases that I come across while I was working in Arrow Park Hospital. As I'm saying, my name is Dr. Mo Bahari, one of the neonatal consultant. I come across this case when I was at Arrow Park. Sadly, I'm not working there anymore, and I'm at Norwich Hospital now, neonatal unit. This case is, in terms of imaging and fancy stuff, there is no that much, but it also addressed a topic that I thought maybe we need to think about it, especially that the new focus group is growing, and this is an area I think we need to pay a little bit of attention to. So let's see if it is. Yeah. So hopefully the objective of today case presentation is first of all, it's an interesting case, and then hopefully by discussing this case, actually we can contribute to improving patient care. I have nothing to disclose, and let's go to the case. So this is a twin pregnancy, die. Born at a level 2 by C-section due to absent end-diastolic flow in twin 1 at 33 plus 4 weeks, and both develop RDS, which is common, and required surfactant administration. Let me see, is it moving? Yes, yeah. So twin 1 responded well to CPAP and surfactant, improved worker breathing, and actually reduction in oxygen requirement. And I think it took 6 hours or 8 hours before twin 1 actually go into low flow oxygen and eventually room air. So it was nothing surprising in his journey so far. But twin 2 was a different story. So it's almost a tale of two twins. So this one was born in good condition, no resuscitation required, but had a little bit of poor oxygenation despite having adequate PEEP and FiO2 administration of almost 100%. He was intubated and given 2 doses of surfactant at level 2 NICU, and one in the delivery room, and the other one subsequently was given in the NICU. Tube position was confirmed by the X-ray and was pushed down further by the transport team. He was ventilated from 20 minutes of age. He was put on SIMV 26/6 and in 100% oxygen, but only saturating 80 to 85%. And that's pre-ductal. Early blood sugar was a little bit low, less than 2 millimoles, so he was given glucose bolus and was put in IV fluids. He developed a little bit of hypotension. His mean blood pressure was at 31 millimeter mercury, so he was given a normal saline bolus at 10 mils per kg with good response. The gases have always shown good ventilation with normal pH and CO2. So they started on 60 mils per kg per day of IV fluids. Mother was planning to breastfeed, but also consented to donor human milk. The baby was screened for sepsis and was started on antibiotics. The initial CRP was almost 0, actually. Then baby transferred to level 3 for further management and started on phototherapy when reached level 3 for jaundice. Urine output was good, 4 mils per kg per day. Neurologically active, moving his 4 limbs with good tone prior to starting morphine and midazolam. And at that stage, there was no head ultrasound yet. His examination showed there is no dysmorphic features. He was well perfused, good air entry bilateral, heart sounds were normal with no murmur, and peripheral pulses were intact. Abdomen was soft, no concerns. Actually, bowel sounds were there, a little bit sluggish. Normal genitalia and anus appear to be patent. So the registrar on that night called the neo on call, mainly because of failure oxygenation. Saturation were at 75% despite 100% oxygen. Blood gases still showing normal pH and CO2. And baby ventilation were switched from SIMV to PCAC, pressure controlled, assist controlled volume targeted ventilation, and was giving another dose of surfactant. Started on muscle relaxant infusion, ROC, and saturation has improved a little bit to 91%. However, it didn't last long. Then ventilation switched to high frequency oscillation and started on nitric, but still oxygenation didn't make any difference. He developed low blood pressure and was starting on dobutamine, and that is his X-ray. And you can see like the lungs are well expanded. The heart size looks okay. Nothing that's significant. Maybe the ET tube need to be pulled back a little bit. There is a little bit of rotation on the X-ray. However, nothing can explain why this baby doesn't oxygenate well. I mean, so far the working diagnosis was persistent or acute pulmonary hypertension or failure to transition compared to his other twins. But so far there was difficulty oxygenating this baby rather than ventilating. So we did an echo. This is the first image. Let me see if it's run. So this is basically a subcostal, and you can see here your right atrium and left atrium, and your atrial communication. And this one is with color. And you can see the SVC entering there, but also there is some element of right to left shunt through the PFO. But good contractility so far. And this is a short axis view. I mean, so far, so good. I don't know if anyone can find anything that doesn't look right so far. And this is a short axis view, just looking at and you can see that the right ventricle is a little bit dilated. I mean, he's at this stage, he's around 6 hours, 8 hours old. So sometimes you can see this in babies who haven't transitioned yet. Mitral valve looks okay. There is no pericardial effusion so far, nothing out of the ordinary. And this is just color, and there was no VSD or flow or shot. And this is still a subcostal, and here you can see that the right ventricle outlet and the left ventricle outlet is a little bit, you can see a little bit, but here where things actually start to getting a little bit different, and it's not the usual image that you see when you do this view. And this is just with color. And then when we did the long axis parasternal, and I think you can see there is that this baby has a TGA, and that is the left ventricle, right ventricle, and you can see that the classical picture of when you're having a TGA, which that now can explain why there is a failure of oxygenation. I think baby at this time was around 10 hours. So basic on this views, this is one with good flow and small duct actually. The left to right shunts and the duct wasn't that great. So Basically, this baby has a TGA with intact septum and a little bit restriction of flow across the PFO and the duct. And you can see it clearly here in the, this is a subcostal view where you can see the right ventricle here and actually attached to the aorta, and you can see the arch here going all the way down. Which so we discussed with cardiology at Al Dahay. The baby was started with prostaglandin E2 and inotropes. It was a little bit difficult case for cardio. Well, it's not difficult, but they had to have the discussion with the parents as the baby was a premature, and the weight at that time, I think the baby was around 2 kilos or 1.9 kilo. So they had to make a discussion with the cardiothoracic surgeons, and they agreed actually they can take the baby. So the transport team has to come back again and pick this baby in the morning and take him all the way back to Al Dahay, where he went for a urgent, actually went straight to the cath lab. At that time, his saturations were around 70, 60, and his gases actually started to become more metabolic acidosis. So in summary, this is a preterm baby born in level 2, required ventilation from birth with no response to ventilation and surfactant, transferred to level 3 neonatal unit with no access to cardiac service. Diagnosis was missed during antenatal care, and diagnosis was made almost around 12 hours of age. Baby had to be transferred twice before reaching the cardiac and surgical services. Which bring me to the topic today of should point of care ultrasound be part of neonatal transport? Which is because the question came up whether if a quick sweep this baby, because at that time before the baby comes to us in our part, already the oxygenation showed that actually baby's oxygenation is not improving. However, his saturation and his CO2 and pH were within normal, so it could be pulmonary hypertension, but also there is also a chance that it could be some congenital heart defect. And I look at this subject just to see, because there are many benefits to having the new transport team to be able to do point of care ultrasound. It's a rapid assessment. Especially if you're looking for pneumothorax, cardiac tamponade, where you can actually do intervention, can tell you about the fluid status, can give you a little bit procedural guidance, especially with long line, as we have seen before. And also you can see if there is the severity, if there is any ventricular hemorrhage. Some places they can use it for neck, but I haven't seen that, to be honest, in practice. The good thing is that nowadays there's always an ultrasound machine around in the unit, even if the transport doesn't have one. But portable machines are available nowadays, and you can have even those that you can probe where you can attach it to your mobile phone. It doesn't give you the best quality images, but at the bedside, you don't look for that accurate details. It can improve decision making and treatment and enhance patient safety by taking the patient straight away to the right place rather than they have to transfer the baby twice, especially where here in UK in general, we have a little bit of fragmentation of service. Not always the cardiac or the surgical unit are in the same place where you have maternity service. Or also it can help with because hospitals like Al Dahay, cardiac or PICU, bed occupancy always run around almost 95 or 98%. So if they don't have a baby who turn out to be not to be cardiac, that would be a good thing. So the other consideration is training. whether so you have to train physician, or you have to train nurse practitioners or transport nurse on how to do it. And there is always the fear there is about quality assurance that we sometimes are missing or overdiagnosis a certain condition. So I thought to go to the literature and see what is over there. Is this issue has been reported upon before or not? And I looked at this. This is the one I have seen from 2016. So that is actually, it's not a new issue. And you can see that I believe that it was done by Nick Evans from Australia and New Zealand. And they were trying to see the feasibility and the utility of portable ultrasound during retrieval in sick term and late term infant. They did actually, it was a clinician, and they did cardiac and cerebral ultrasound. And I think they were out of 11 babies were suspected of having heart disease prior to retrieval. 8 were confirmed, and 3 turned out to have normal structures. So there is a good way now at that stage before transport to decide where this baby is going. And interestingly, just from a head ultrasound perspective, some of the baby actually had a little bit worse IVH after transport, which is quite interesting. And they did the same thing, I think, in the next year, just looking for sick preterm babies. And also in terms of, they were able, one of the babies, I think they were concerned about pulmonary hypertension, and turned out to be congenital heart disease. And they were able to redirect care to the destination, to the appropriate place. And also we have a case here, our case report from UK, where actually it's called an echo on the go, where by Mohsen et al, where actually showed that by able to do an echo on transport in the hospital, that referring the baby, they were able to actually redirect care, and this determined that the baby doesn't need cardiac echo, and actually it was just pulmonary hypertension, persistent pulmonary hypertension of the newborn, and the baby eventually improved clinically, and didn't actually have to move the baby. So that's one of the benefits of having to be able to do a quick point of care ultrasound. This is also another one, just this one mainly speak about whether it is feasible actually, or how difficult it is to train non-physician. And basically in this study, they were trying to train registered nurse or transport nurse and respiratory therapist. This is from North America. I think this is from Calgary, where they trained, it was a prospective educational study, where they trained staff, non-clinician doctors. They gave them clinical sessions and practical sessions. And then they said, how long does it take till they actually able to obtain satisfactory images? And I think it takes, the average was around 8 hours, which they could enhance clinical care and transport, especially in the places, I mean, for them, it was the transport usually average will be around 8 to 6 hours. So it will be a while till the baby to be able to come. So that will give them immediate information and immediate clinical ability to make clinical decision in terms of how to manage a baby with hemodynamic instability. This also another study which was done in 2019, which showed that actually lung ultrasound may be actually a remarkable technique in determining what's the cause of respiratory failure before neonatal transport, and also it's able to optimize the care before starting the management before, so that actually will help the outcome. And I think we have this one, which was done recently in 2022, where they wondering whether actually doing lung ultrasound during transport will affect the quality of it, especially with the vibration. And I think in this study, they tried to do lung ultrasound before transport, during transport, and receiving babies in the neonatal unit, where they compared the three studies, and they found actually there is no variation in terms of, for example, scoring, and it didn't affect it at all. So it's possible, not only being able to do point of care ultrasound before transport to decide what kind of management or intervention you need, but even monitoring the baby during the trip and acting accordingly. And it provides reliable information. And the last thing, it is not that difficult, and especially I hear this sometimes from trainees or learner or some nurse practitioners or transport nurse, that it is difficult and sometimes it takes a lot of time to get the skills. But in this interesting study, which called Hocus-Pocus, where a cardiac unit, I believe it was in the state, where they actually trained the parents on how to obtain certain view, short axis view, and long axis peristernal view, and basically trying to follow up this cardiac baby in terms of cardiac function and shortening fraction. And they were able to, after training, to able to compare the images that actually were obtained by parents and compare them to the images that were actually obtained by sonographers or cardiologists in these specific views. And actually, most of them, 96% of the parents were able to obtain credible images and showed that there's no difference between the ones that they obtained. So imagine how this will be helpful for follow-up of a cardiac patient at home for the cardiology team. So I know at the time that at present where we don't have enough staff or enough nurses for our own, to fill shifts or team, but I think it's something that we need to keep at the back of our minds, and especially nowadays where we have a lot of babies. I remember, I think that the last recent publication about this showed that there are more babies are being born, preterm babies or term babies that are born not in where they're supposed to be, whether it's surgical or cardiac or premature, and they have to be transported to a level 3 or a cardiac or a surgical place where they need their proper treatment. I believe if we have obtained the skills or we provided the skills and the support for the team, whether it's doctors, juniors, or a nurse practitioners, to be able to obtain these images, and with a little bit of IT support, even if there are concerns or not sure what they are able to see, they can share the views with an neonatologist or even a cardiologist at a certain base, or where they can have a quick review and decide what the next step is going to be. So despite we being busy, I think there is always a room for improvement. So I think I reached the end of my presentation. I'll stop sharing now and see if there is any questions. But I would like to ask first, how many of you believe that having a point of care ultrasound for this case would have altered or made this baby go from, instead of coming for a level 3 with no cardiac support or surgical support, to go straight where it's supposed to? I don't know if, is there a way to set a poll here? No, not at my end, sorry.
I'm not sure. Yeah. I mean, it's not a very short answer to be able to do. I think Saul has his hands up. Is it okay, Mo, if Saul fires away his question?
Yeah, sure. Yeah, sorry, I didn't see that.
Okay, so Saul, please go ahead.
Yeah, Mo, thank you very much for raising presenting this case, and actually raising the question about where is the place of focus and who should be doing. And I really grateful you just put it out, because there are two things. First is a clinical, and I would leave that because your question was about who and should be doing the echoes and how should they be assessed. And then let's put it this way: you just show to the paper that you can train parents to look at the scans and to show how to do that. So I think looking at the bigger picture, I think we're coming to the stage when neonatology without ability to assess lung or heart function, or let's say DQ, is becoming like other shortcoming. And it's irrelevant whether you are on the level 2, level 3. I would not talk about level 1, let's put it this way. Because level 2, the guys dealing with the babies born over 28 weeks, they do have echo machine, and they can actually learn echoes and actually be able to do simple images. If they can't interpret, the next question is like how to arrange in this digital world, the images to be reviewed by somebody who understands. Let it be that level 3 consultant who actually knows hemodynamics, or it's cardiologist, and doesn't really matter. But the point is how you can actually make an assessment. And this is one way of doing it. Another way is you raise the question about transport team doing the scans. It's good. But then you actually have every transport team to have their own scanner, even handheld, which in fact actually have a lot of shortcomings. But when you come up in the unit and you don't know, I do transport, let's put it this way. So when you come to the unit and you have a completely unusual machine in front of you, it's difficult. So you have a handheld that is not really giving you a good views or a good pictures. And then you have the local machine, which is much better in the views, but you may not necessarily use up to the best opportunity. So, and then you actually have to input a lot of money to have the handheld, echo devices or ultrasound devices. They can give you a certain amount of the lung ultrasound and certain amount. So, to summarize it, I think your question reflects more or less where we are in the threshold of the going from the old neonatology to something that most of my colleagues may not necessarily want to admit it, but this is the group of believers. I can tell you one thing. And this is exactly why I'm so grateful you're putting this, because I think there is, in this period of time, it comes from that you cannot really carry on like you did. You actually need to be able to do more than you did. And I'm really sorry if I'm sort of, okay. So the answer to your question is, I think anybody who is delivering the babies, or at least the team who deliver the babies, need to be able to have the skills to put it in. And if you say that 8 hours for the team that actually are on the floor, they do have dedicated time to learn that. That's a simple thing. And they have a scanner. So this is a given. So they are comfortable with the scanner and do. So that would be my first answer to your question. Transport, that's like a backup plan. I would think about it. Unless, and I would pretty sure that in the 3 or 4 years, you will have much better handheld scanner devices that specifically, and especially for neonatal team, they will be able to do things we not necessarily be able to see right now. And the last thing is, in your case, coming back, you have a good ventilation, you're actually not oxygenated. You're on 100%. Look at the textbook, and this is actually look at the cardiac condition. So the next thing you need to do, go and put the scanner and look at the heart. And that is not criticism. This is like my old, how to say, clinical training and clinical experience will do. And thank you very much for putting this out. I really appreciate that. Really, really.
Yeah, thanks, Hassan. I mean, you raise all valid points. I I think yes. I mean, if there was anyone from the local hospital had the skills to do ultrasounds or point of care ultrasound, not necessarily a cardiac one, just a quick one, just to see if the heart is contracting, anything that doesn't look right. But I don't think they had that skill. And the advantage of having a transport team, because neonatal transport team is highly specialized and come in support local unit. Not, I mean, like even in terms of ventilation, in terms of intubation, or sometimes central access, because even unit level 2, level 1, you will have sometimes pediatricians and sometimes neonatologists, and we know nowadays about the exposure or the what you call it, the case overload, and sometimes you may not be able to do all this. We do know that um, many doctors actually they do point of care ultrasound, which in terms of head ultrasound, which I mean the first thing that learner comes in new to the unit, it will take 1 or 2 days, and then they will do the head ultrasound. I don't know if that will be something that in terms of point of care ultrasound was something a little bit simple, lungs, looking for pneumothorax, or even quick focused areas where you need to look at function or filling, or major heart defect like a left left hypoplastic heart, which sometimes can get missed during pregnancy. But I think having the service with the transport team is a backup, just in case it's not available, if the local team doesn't have it. And nowadays we have, I think, good IT support where you can send those images to a cardiac or neonatologist who can interpret them and make a decision if the operator themselves are not familiar or are not sure about what he or she is seeing. The other thing that I know that even when neonatologists started picking the probe, a lot of people were a little bit hesitant. There was a lot of pushback. What about if we miss major cardiac defects? And actually studies after study, one of them was done by Nick Evans himself, showed actually there is no, in terms of how that cardiologists can miss and neonatologists can miss, is not that much difference. But it depends. We're not talking about that level at the bedside for a transport team or even level 2, level 3. Basic views, if they have done it a quick sweep for a chamber view, would they be able to notice that there is not that there is an abnormality, that maybe this baby need to go to a cardiac rather than going to a level 3. So that's where I'm coming from. I hope I answered some of your questions, Has. I see.
So, I think Tina has made a comment. Tina, would you like to speak, or are you happy with this just in the chat box? I mean, it's a long comment. Would you like to say something?
Hi everyone. Sorry, I didn't mean to kind of clog up to conversation too much. I do believe what Mo is saying about it. I think transport teams would be a good first point to train, because they're, as he said, highly specialized. There's not that many of them, and they see a lot of these babies where it would be very useful for them to be able to do POCUS. And they could have now device things and everything is something to talk about later on. But yeah, when you were giving the presentation, I was thinking, oh, if only the transport team would have looked up. Yeah.
Yes.
Great. Thank you, Tina. Lucinda, your hand is up, please.
Hi, yeah, thanks for the really interesting talk. I guess I looked at it slightly differently. So I work in a DGH and I'm a PEC in a DGH. And I'd slightly worry about transport teams. Obviously, if they could all echo, it would be great. But our local transport team, the registrars rotate every 6 months. And so it would be quite a lot of juniors you were trying to teach on a rolling basis. And it's not really POCUS you're asking them to do, because cardiac POCUS is excluding tamponades and looking on contractility. But what you're already talking about is excluding things like TGA or obstructed TAPVD, or sort of things that are properly congenital heart disease. So I think, yes, if everybody could do POCUS, that would be amazing, but it still wouldn't necessarily diagnose things like TGA unless our scope of POCUS changed. Equally, I think more and more hospitals have PECs now, and so maybe actually we should be, because a PEC in a DGH is super useful for not just this situation, but for, you know, any cardiac thing. So maybe actually the push should be to have more locally trained PECs everywhere, who can do proper scans more than just POCUS.
I just want to say that as part of learning, especially if you're looking at the heart as point of care ultrasound, I think it will be important just to know at least what's normal. You don't have to diagnose what's abnormal. If the views looks different from, you know, like from a used to do, or the things like different from the 4-chamber, you know that this views are abnormal. And I think at this point that where you need to think, does this baby still can go to a level 3 with no cardiac support, or this baby need to go to a level 3 where there is cardiac support? I think that's what I'm thinking about. I don't know what the rest of you guys think.
I
Rajat,
can't
can I come back?
see. Yeah, please do.
Guys, I respectably disagree with the putting the pressure on the transport teams, and is definitely my colleague just before saying that is that when most of the transport is made by registrars, it's a consultant job to learn a new pictures. And more coming back to your case, if you do the long axis view and you put a very simple position of the two long running the vessels, that's a diagnostic. So you don't even really need to have the structural echo skills. You make that picture, you show that to either level 3 consultant, transport consultant, or the cardiologist, and they will actually know what to do with this baby. That's a simple things. I think, again, we're talking about the case, but I'm trying to put you on a bigger picture. You know, and if you actually measure the picture, bigger picture, that you need to be able to do things more than you used, let's say, 5 years or 3 years ago. If you don't accept that, then you will be talking about who's going to be doing it. If you actually want to really progress with the neonatologist going forward and to help the babies, then you need to accept that neonatology without the skills using the ultrasound machine has not got a future. And for that, and if you start from there on, together with the clinical skills, that's when you do. And you don't need anybody to be able to do the scans or to do the full function. You just need to have a standard pictures. And these standard pictures already show. In your case, it's obvious, it's straightforward, it's clear. Actually, clinically is already clear about after the 3rd dose of surfactant, that is actually something not right. But that's a different story. Thank you for that.
Thanks all. Thanks everybody. Sorry, I'm just jumping in a little bit late. I think we should have kind of a balance of having the skills in transport, but also relying on the clinical sense, because transport teams are different in terms of structure in different places. As Lucinda said, some teams are dependent on registrars who rotate every 6 months. Some other teams are dependent on consultants who are permanent in their job, and probably they are the best people to develop those skills. And maybe a hybrid or combined approach that while we teach people in their training posts about POCUS, we also upgrade the skills of the transport team about POCUS. And many NNPs would be keen to do that as well. Like, you know, some people in London and Bristol are quite keen to learn about that. So probably that's the way forward, I think.
It is true, Mahmoud, that I mean, in some places, actually transport is led by consultant. In other places is led by nurse practitioners, and in other places led by registrar. So there is a huge variation in the setup of the team. I think it's better that each unit or each service see what's suitable for them. But I think there is potential here that if you have someone who's permanent, or especially nurse practitioners, because even consultant transport, they have a high turnover compared to nurse practitioners. So if you're going to invest in training, I would go with the nurse practitioner rather than the consultant. But these are my views.
Okay, can I make two quick comments here? So I think we all agree it needs to move in this direction. There should be a transition, and with a balance and safety training, and probably the transport teams should be trained first before the local ones. However, number one, I just don't feel very comfortable with the idea of having a quick screening echo. To me, that doesn't exist. It has to be thorough. It has to be a very reliable procedure done, because you see, you're talking about making a decision which is very directly related to morbidity, maybe mortality. So a screening echo, what exactly is that? I think it should be a full one, as definitive as possible, which is a more difficult task from a training and point of view, but we are looking at it from a patient's point of view. And secondly, even when I have, so I walk in with as a transport team person in a level 2, I've echoed somebody. So no matter what the degree of experience, because you're entirely changing the management, you're turning the helicopter direction in a 180 degrees opposite to somewhere. So one person, it shouldn't be thrown on the shoulder of one person, that big change in decision. Mo, you did say technology, IT, so that sort of resource should be available, that a cardiologist or a buddy neonatologist should be able to see the images and say, okay, we're not driving in this direction, we are driving in 180 degrees opposite direction. And so these 2 points, and both are about the transport team doing something prior to the transport. So they look at the airway, they look at the access, and they often do, or not often, but sometimes they do new access. They sometimes even intubate or at least adjust the ET. So they do a lot of work prior to getting into the ambulance. Now it's a completely different ball game when you're in the transport. So if I shouldn't be doing an echo mid-air and say, oh, I found a transposition and turn the helicopter around. So there, an acute deterioration can be seen by a person who's good at POCUS. So in the transport, prior to transport, there are two different things. And prior to transport, I think echo should be a good one, and two, supported by somebody else as well who could see. Thank you. Great. I think there are no further questions in hands. Mo, thank you very much. This really was a presentation, as you texted me, short and sweet. It really was sweet, and I think the clarity with which you presented this and you diagnosed this was just amazing. Thank you for sharing this case, and a very thought-provoking question that you posed as well.
Thanks for having me.
So we'll meet.
And I think
it's a pleasure. So we'll meet. Sorry, please go on.
No, yeah, I think it's just it's something to be, maybe it's a little bit early or something like that, but I think with something just to keep at the back of our mind, especially that the new POCUS or the POCUS is growing in terms of service participants and practitioners. So something to think about rather than go straight and implement it straight away.
Yeah, thank you, Mo. That's the vision for the future for sure.
Yeah.
Thanks everyone for joining.
Thanks, guys.
Okay, thank you. Bye bye. See you later.
Thank you.
care.
Thank you.